So I want to just go through a few things that you'll learn when you start looking at a CT scan from the same day that you get a chest X-ray, so that you can kind of actually differentiate certain structures. So let's just go through the basic process with this guy here. Um, he looks reasonably square on. Clavicles are either side of the teardrops, which are the spinous processes, and the trachea is all in the middle. But in the general sense, his lungs look a little bit long, and we'll count ribs posteriorly. So that's the first rib at the back where the transverse process is, and at the front. So that's 1, 2, 3, 4, 5, 6, 7. They're starting to get a bit hazy. I'm going to go 8, T9, 10's about there. You can see it on that side. And then that's the 11th rib. So if you're getting towards your toes where the diaphragm is, again in terms of vertebra, it's about T11, T12, T11. So that would be too many, and he's hyperinflated, and they look kind of flattish. The lung fields themselves look reasonably black, but bits of them might be too black and white, and some of these changes look to me structural, like they look like holes and walls and voids, which when you've seen a few of these start to make sense. There might be a little slight haziness in the right lower zone. Now the walls and voids, if I can click this the right way, look like that. There's just structural, so inverting the white balance, there's just structural walls and voids to the white pixels, which is a hallmark of lung destruction in COPD. Let's just go back to where you are. And what it means is over here, so that's the trachea. And again, this is the front, it's the back, it's the patient's right, the patient's left. And as we roll down, these bits of lung. So there should be little wisps of blood vessels and lots of little alveoli in there, but that's just a hole. Yeah, and this is smaller holes, and the lung tissue has actually been destroyed. These are big bullae. Seems to be a bit of pleural thickening here. But this is what I mean about the structural walls and voids. And again, if we invert that, walls and voids, so not lung tissue, but just big empty space that's lost all the alveoli and lost the elastic recoil. And when you lose elastic recoil, your lungs don't exhale passively, so you need to exhale actively. And when you start exhaling actively, you're pushing on not just lung, but pushing on airways, and that's what makes that wheezy sound to some degree. So walls and voids, and then fibrotic structural changes. I don't know exact smoking history, but probably extensive. So again, fibrotic changes coming down. So these are holes, and then some of this is okay lung tissue. And then, these enhancements, which may or may not be problematic, but certainly something that, would excite investigation at some point. So again, this what looks like foam is just walls and voids in COPD lung. So lots of holes, lots of bullae everywhere. One thing I didn't note earlier, but there almost looks like a bit of a gap there, because I think he had a bit of a fall. And if I enhance, see there's a gap in the rib there, and there's a discontinuity between the rib there and there. So there's one there, and you kind of look up, there could be a little gap there. There's certainly a change in angulation here that this wire is running through, and then maybe to some degree there. But sometimes they're more visible on the CT, and sometimes they're not. So again, lots of just holes where there should be lung tissue. Like the lung should kind of look like this, a bit of a fuzz of white pixels everywhere, not empty black space. So this airway does look a little bit thickened and dilated, running next to the blood vessel. A hallmark of bronchiectasis is an airway that's the same size or bigger than the blood vessel. Generally, the blood vessel should be bigger than the airway, with thickened walls. And that's part of the process of COPD, the loss of elastic recoil and the emphysema changes, the bullae, and then the chronic airway inflammation, the bronchiectasis. So both of those contribute to increased secretions, airway narrowing. So again, lots of holes, walls, and voids. I feel like there's a little weird gap there. So as we work our way down, there looks problematic. So I think he'd had a fall and some rib fractures. There's a gap there. But no obvious bleeding or anything into the pleural space. And then coming up under, this is the left side, and under your diaphragm on the left is your stomach, and the spleen at the back, and then on your right is your liver, and there's lung all the way down there. And then gas in the stomach and gas in the bowel, but it's contained. So we have just emphysema changes all the way through. We have some rib fractures. We have, again, this displacement, but no damage to the lung, no pneumothorax, and no issue of there, no issue of hemothorax necessarily. And then let's just bring up a more recent X-ray. So he had some other issues and unwellness, and you can see this now. Increased opacity, lower zones, his left more so than his right. And he had a few incidents between then and now that led to him coming to the ICU. But yeah, this is what emphysema looks like on CT, and then what to look for in terms of the walls and voids on X-ray, inverting the grayscale, and kind of idea of how that looks of this weird foam when you invert the grayscale on the CT.